Welcome to this American Society of Nephrology Kidney 360 podcast. I am Dr. Juan Carlos Velez. I am a professor of medicine at Oxford Clinical School in the University of Queensland and the assistant chair of the Department of Nephrology at Oxford Health. I am joined by my colleague and peace prophet enthusiast, Dr. J.L. Stelzer, chief of nephrology at the Missouri Baptist Medical Center. Today, we will discuss our study entitled Urinary Vacuolar Casts are a unique type of cast in advanced proteinuric glomerulopathies, published in Kidney 360 in the month of January of 2024. So we'll start asking my co-author, Jay Seltzer, what are vacuolar casts?
Vacuolar casts are a distinct type of urinary cast characterized by the presence of multiple clear vesicles of various shapes and sizes within the cast matrix. Notably, these vacuoles are not birefringent under polarized light, a feature which helps distinguish them from lipid droplets within casts. In addition, whereas lipid droplets are typically round, the vesicles in these vacuolar casts are various shapes, round, oval, or other irregular or elongated forms. It's also important to differentiate vacuolar casts from red blood cell casts, as the red blood cells in casts typically reflect the presence of a glomerulonephritis, such as a pauciimmune, IgA, or immune complex, GN. Vacuolar casts, as we're going to discuss, have a different connotation. One key distinguishing factor is that red blood cells in RBC casts are all the same size and maintain their configuration despite being confined to a cast matrix.
Great. Next, we're going to go through the methodology of our study. So, taking advantage of a social media educational platform, Twitter, we established a multinational collaborative network of nephrologists and laboratory medicine pathologists interested in urinary sediment microscopy who had encountered cases in which vacuolar casts were identified during clinical practice. Pulling clinical and histopathological data from centers across 4 continents, we compiled a total of 46 cases. Our center at Oxford in New Orleans contributed with 72% of those cases, whereas the remainder of the cases came from centers in Brazil, Mexico, United States, Switzerland, India, and Philippines. The primary objective was to describe the clinical characteristics of patients presenting with these casts. Furthermore, we aim to examine the relationship between the presence of urinary vacuolar casts and the associated renal parenchymal process. Thus, we extracted cases in which a kidney biopsy was obtained around the time of the urine microscopy and a histopathological diagnosis was available. Those patients represented a fraction of the 46 patients, precisely 26 patients. For comparison, we also established a cohort of patients who, during the same study period, also underwent kidney biopsy at Oxford Medical Center, but lacked vacuolar casts in the urinary sediment. This control group consisted of 186 patients. The key findings of the study were the following. The first observation was that the majority of the patients with specimens with vacuolar casts had a glomerular disease, had overt proteinuria with a median urine protein to creatinine ratio of 6.1 grams per gram, and had advanced kidney disease, with 62% presenting with stage 3B to 5 of chronic kidney disease. Hypertension and diabetes mellitus were relatively common. In most cases, vacuolar casts were found in sediments also containing other casts, such as granular, waxy, renal tubular epithelial, red blood cell, lipid casts, or others. In other words, it is unusual for these casts to be found in isolation. When compared to cases in which vacuolar casts were not found, patients with specimens with vacuolar casts had higher degree of proteinuria. Moreover, when only cases with histopathological diagnosis were examined, again, presence of vacuolar casts was associated with worse proteinuria and greater degree of glomerular obsolescence. It is also worth highlighting that the vacuolar casts are not specific for any glomerulopathy. In our study, some of the pathological diagnoses included diabetic nephropathy, arterial nephrosclerosis, thrombotic microangiopathy, podocytopathies such as FSGS, collapsing glomerulopathy, and membranous nephropathy, proliferative glomerulonephritis such as cryoglobulinemic and infection-related GNs, among others. The next question is, how were these vacuolar casts created?
We still don't know how or why these unique casts form. However, we do believe that these vacuolar casts originate from the degeneration of renal tubular epithelial cells containing vacuoles from prior injury already incorporated within a cast, or perhaps from vacuolized podocytes. In 61% of our cases, the kidney pathology revealed either vacuolization in renal tubules by light microscopy or in podocytes by electron microscopy.
Great. So we'd like to present the conclusions of our study, where number one, vacuolar casts are a unique type of structures identified by microscopy in the urinary sediment of specimens from patients with acute or chronic kidney disease, and these casts should be incorporated into textbooks and pertinent medical education material. Number two, in most instances, patients with vacuolar casts are found to have overt proteinuria, commonly in the nephrotic range with advanced disease state, either CKD approaching stages 4 to 5 or severe forms of acute kidney injury. And whether vacuolar casts offer a prognostic value beyond estimated GFR and proteinuria remains to be determined and would require further study via prospective examination. For now, it is important to raise awareness of the existence of these unique urinary casts and avoid misinterpreting them as lipid or RBC casts. So on behalf of my co-author, Dr. Seltzer, and I, thank you for listening.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.